As treatment goes along, do you ever rebiopsy? It's not. If not, is it because it is cost prohibited, or is it assumed that biopsy will always show cancer to some degree?
Biopsy sometimes because we are looking for new therapies. So we know that the disease evolves over time. We know that if the patient is developing new new lesions which are resistant to the present therapy, we want to know why. In some cases, we find that the morphology of the cells is changing, what we call like large cell transformation. We may find out that the cells are growing at a much faster pace. That's important for the clinician to know. Also, one other important aspect of rebiopsying is to study if there is any molecules at the surface of the tumor cell which may be a target for us. We know that we have targeted therapies against several molecules now, and the absence or presence of those molecules in the tumor is going to provide some guidance to the doctor about what's the best way to treat the patient. So do we biopsy the patients? Absolutely. Another issue is that sometimes a lesion that may appear to be disease progression may turn out to be something completely different. So before we jump into a new treatment option that can cause harm to the patient, we like to make sure we are dealing with the same disease and not something that may require a completely different therapy.
If the visible spots for patients with stage 1A MF disappear, how often would you recommend your patient to check?
That's a good question. I would say there's sort of two approaches to that. One is how often should your doctor check in on you, and how often should you be checking in on yourself at home? The truth is, I would say I wouldn't be searching for spots. I would say if you feel a spot that's bothersome, sort of it's itchy, scaly, and then you notice it, then I think there's really no urgency to start treatment and to be on high surveillance. So I think it's reasonable to let your body call attention to it. With that said, there's some areas of their body that are, readily visible. And so if you see us, certainly can have a discussion with your primary caregiver regarding what's the next best step in terms of treatment. But I don't know that I instruct patients to actively look for spots, but rather if they notice a spot, then we can talk about treatment at that time. In terms of how often I see patients, it really depends on a number of factors, from have they newly been diagnosed, have we started a new treatment, and I want to make sure that they're using it correctly or not having any difficulty. So I might see patients with 1A mycosis fungoides as often as 3 months or as often as a year. So it really depends on where you are in your disease course.
So what hematological analysis are necessary to stage the disease in the case of LYP? It's a little bit more of a lab question here.
Sure, I can answer that one. So patients with lymphomatoid papulosis, well, I guess let me take a step back. I think the first step is to really establish whether the patient has lymphomatoid papulosis versus some other form. And in that initial workup, some blood tests may be done. But once you feel confident that a person has lymphomatoid papulosis, at that point, some of the blood work that gets done, and it's blood work recommended by the National Comprehensive Cancer Network, is just a basic, complete blood count, a test called LDH, just to get a sense of active inflammation. And these tests are really seen as sort of a screening test to see if there's any other potential cancer-like processes going on within any given individual. But we do not think that LYP affects the blood. So there's no kind of blood work specific to LYP staging that gets done, but rather blood work that gets done to evaluate whether or not this person is at risk for having another form of cancer.